All right. So I'd like to welcome everybody to Pediatric Grand Rounds, remote edition. Today it's my pleasure to introduce Dr. Victor Smith. Victor is a third-year pediatrics resident here. He went to University of Tennessee, Knoxville for undergrad, and then went to Georgetown for a MS degree and earned his MD right here at Quillen College of Medicine. Dr. Smith is going to San Antonio to practice NICU. And he's neglected to mention he is also one of our chief residents, so I'm glad to have him speak today on congenital neonatal infections. One other thing I wanted to cover, if you have any questions for Dr. Smith after the presentation, there's an area on the webpage to communicate via typing, so definitely we'd love to hear from you. Dr. Smith?
Okay. All right, so today we're going to cover a little bit for congenital neonatal infections. Joining me as well for this presentation is Demetrio Macariello. All right, so here is covering just a little bit of congenital neonatal infections. Nothing to disclose for this. So some of the objectives that we'll cover today. So just in general discussing the overview of congenital neonatal infections and what they mean, as well as some common infectious agents implicated in congenital neonatal infections. As we go through them, so congenital neonatal infections affect the unborn fetus or newborn infant, generally caused by viruses that may be acquired by the baby at any time during the pregnancy up through the time of delivery. TORCH is an often used acronym. It's basically denoting chronic non-bacterial perinatal infections. However, it's important to note that the O of TORCH is the other category, and so as such it ends up encompassing a lot of other infections. In addition to that, we'll be covering some of the most common ones, but it's not all encompassing for every possible congenital neonatal infection. Looking at this, so congenital neonatal infections, the majority of infected infants are actually born to mothers with an asymptomatic infection. A mother can have an illness, but it's often nonspecific. And then in addition to it, there is often a point at which laboratory testing and follow-up can allow confirmation of the congenital infection. It's important to be able to realize as well that for a lot of these neonatal infections, it's important to be able to catch them early, not only for just the therapeutic advantage that they then provide for treating the infant, but in addition to that, it's also then becomes very clinically challenging to be able to determine whether or not that was a postnatal infection versus a congenital neonatal infection. The viruses initially infect the mother, who subsequently passes this on to the baby, either directly through the placenta or at the time of delivery. And then there's a number of common viruses that are linked to congenital infections. The common ones that are seen for TORCH include Toxoplasmosis, Syphilis, Hepatitis B, Varicella, HIV, Parvovirus, enteroviruses, Rubella, CMV, and HSV. So now we're going to talk a little bit about toxoplasmosis. So it's caused by Toxoplasma gondii. It's an intracellular parasitic protozoan capable of intrauterine infection. It's spread via fecal-oral route, and then domestic and feral cats are the definitive hosts. Infant incidence is about 1 in 10 per 10,000 live births. So that's about a total of 400 to 4,000 cases of congenital toxoplasmosis occurring each year. The pathophysiology, so going through it a little bit, so you have an oocyst, a tachyzoite, and then a tissue cyst, that's the bradyzoite. So cats generally acquire the infection by feeding on some kind of infected animal, whether that's mice or an undercooked household meat. They then shed the oocyte in their stool for about the next 7 to 14 days after infection. Of note, cats can shed millions of these oocysts during a 2-week period. Pregnant women then become infected by consumption of raw or undercooked meats that can then contain these cysts. They also can have an intermediate host of sheep, cattle, or pigs that can then have those within their skeletal muscle for a lifetime. Ingestion of the cysts then ends up leading to penetration of the GI mucosa, where they turn into the tachyzoites. At that point, they're then basically able to have the acute infection. Tachyzoites spread throughout the body via the bloodstream and lymphatics. In an immunocompetent host, Tachyzoites are sequestered in tissue cysts and form these bradyzoites, and then that's the chronic phase of infection. Adult acute infection is subclinical in 90% of cases, but then the vast majority of congenital toxoplasmosis are a result of the acquired maternal primary infection during pregnancy. So that's kind of an important aspect to know, is it's that initial primary infection. Of note, reactivation can occur in immunosuppressed pregnant women as a result of, and can result in fetal infection. If an adult infection does occur, it's often, again, this nonspecific mono-like illness, having things like fever, painless lymphadenopathy, fatigue, malaise, and myalgia. Some of the epidemiological risk. So 84% of women of childbearing age are actually seronegative for Toxoplasma gondii. So there is actually a fair chance of being able to have the infection. Following that, it also depends on the trimester at which the woman is infected as to the severity of the disease. So looking at that, it's the likelihood of transmission to the fetus depends on the time. So 17% within the first trimester, 25% during the second trimester, and 65% during the third trimester. Of note, 70 to 90% of infants with congenital infection are asymptomatic at birth. So during the acute infection, again, just kind of going over, the cats excrete these oocysts, and then the incubation period in an adult ranges between 5 and 23 days. It's important to note that the way that it's passed on can also not just be through raw or undercooked meat, but also can be exposure due to cat litter boxes, as well as contamination from soil with gardening or unwashed fruits or vegetables. And so as such, that's one of the reasons that pregnant women are often advised to wear gloves when they're gardening or have really any kind of contact with soil or sand. Also, they should avoid changing cat litter if at all possible, or if they absolutely need to, then it would be to wear gloves and make sure to wash their hands well afterwards. So some risk factors. So again, that's eating or contact with raw or undercooked meat, cleaning cat litter boxes, unwashed raw fruits and vegetables, and exposure to soil. Interestingly enough, cat ownership by itself was actually not linked to toxoplasmosis unless someone had greater than 3 kittens. And so it's actually, it's not that you can't necessarily own a cat, it's just of trying to make sure not to clean the litter box. So transmission itself is transmitted to the fetus during a mother's primary infection, or if the mother is immunocompromised and has a chronic infection. Risk of fetal transmission during maternal infection increases with gestational age. However, earlier in pregnancy that a fetus acquires the infection is the more likely to be severe. So the best way to think about that is if an infant gets the infection within that first trimester, it's more likely to be a severe infection if they get it, but they have a lower likelihood of acquiring the infection. However, if they get it in their third trimester, it's much more likely that the infant would acquire the infection, but it's more likely to be less severe. So some of the clinical manifestations of note, you have infants between 70 and 90% that are subclinical, and so won't have any known symptoms. However, those with a clinical disease will typically have a disseminated disease as well as ocular and CNS effects. The classic triad that will often show up many times is this obstructive hydrocephalus, diffuse intracranial calcifications, and chorioretinitis. Chorioretinitis is the most common late manifestation. The lifetime incidence for untreated infants for chorioretinitis is actually 90%. And then they can also have other eye findings, including microphthalmia, strabismus, cataracts, seizures, cerebellar dysfunction, mental retardation, and sensorineural hearing loss. So some common findings. So just kind of looking at some of these pictures here, which kind of can help highlight some of the aspects for you. So looking at toxoplasmosis, you can have bilateral lateral ventricles on fetal ultrasound. Chorioretinitis is highlighted there at picture E. You can also see, looking at picture B, some of those small calcified lesions. And again, just wanted to highlight an additional picture for you of these diffuse intracranial calcifications, just in kind of highlight that in contrast to some of the other things that we can see for torch infections. So diagnosis. In the postnatal period, diagnosis is strongly suggested by history, physical exam findings, and serologic tests, but again, infants are most often asymptomatic. Postnatal laboratory studies, you can look at IgM and IgG. There's also a PCR that can be performed on almost any body fluid. A positive test really is the diagnostic test for this. Of note that I thought was interesting as well is there's also some universal newborn screening that also will test for toxoplasmosis. So that's another thing, depending on the state that you're practicing in, that may end up showing up. Anytime that there's a Toxoplasma IgM positive result, it should be confirmed in a Toxoplasma reference lab. And in addition to that, this IgM that you're often looking for is typically going to peak within 1 to 2 weeks and remain positive for months. However, IgG typically will take up to 1 to 2 months to actually be coming back positive for the infant infection. So further diagnosis, you can look at ophthalmologic, auditory, and neurologic examinations if there's a clinical concern. If you have a clinical concern, lumbar puncture should also be performed, as well as a CT scan of the head. It's interesting that CT is actually the radiographic technique of choice because it's more sensitive for the calcifications, though you can also occasionally pick them up as well on head ultrasound. Ophthalmologic exam can also show chorioretinitis, so it should also be performed. So treatment, looking at treatment, if the diagnosis is confirmed, it's treated with pyrimethamine, sulfadiazine, and folinic acid for 1 year. Serial follow-ups should be performed, including neuroradiology, ophthalmologic, and CSF analyses. Infants who receive treatment have improvement in their hearing loss, although they remain at risk for recurrent chorioretinitis throughout their lifetime. Additionally, I think it's important to highlight that congenital toxoplasmosis does have a mortality rate as high as 12%. One other interesting treatment aspect was looking at if there was increased pleocytosis of the CSF fluid. If it's greater than 1 gram, then, or if the infant is also having chorioretinitis that threaten vision, prednisone should be considered. And then there's also some aspects that look at if there's maternal exposure that then leads to positive maternal disease. You can also look at trying to use spiramycin to try to reduce congenital transmission, but this does nothing for treating the infant in utero. So now we're going to move on to a different torch infection, so that's going to be syphilis. So syphilis is caused by gram-negative spirochete, Treponema pallidum. Route of infection is spread through direct contact with a spirochete-containing lesion, sexually or transplacentally. Syphilis in an infant or child who has a treponemal test. You can end up looking for congenital syphilis on physical exam, evidence of radiographs or long bones, reactive CSF VDRL, or elevated CSF IgM. Incidence is about 10 cases per 100,000 live births. Pathophysiology associated with it. So importantly, treponemes are able to cross the placenta at any time during pregnancy. Syphilis is known to cause stillbirth, preterm delivery, congenital infections, or neonatal death. Interestingly, there's Kasowitz law, which is the risk of vertical transmission of syphilis decreases as maternal disease progresses. So depending upon basically the time that the mother acquires syphilis changes the likelihood of the disease to be passed on to the infant. So basically an untreated infection within the first or second trimester often leads to significant fetal morbidity. Meanwhile, infants who are infected within the third trimester are more likely to be asymptomatic. Most common cause of death, interestingly, for syphilis is actually placental infection leading to decreased placental blood flow, not necessarily systemic syphilis for the infant. Risk factors, so lack of early prenatal care is the strongest predictor for infant syphilis. In addition, mothers who received inadequate treatment, whether that was a non-penicillin treatment or within 28 days of the infant's birth, also have an increased risk of transmission. Some clinical manifestations. So importantly, majority of infants born with congenital syphilis are actually asymptomatic at birth. So you kind of use two different kind of onset times to classify congenital syphilis. That's early, less than 2 years of age, versus late, which is greater than 2 years of age. Early congenital syphilis is typically seen at 1 to 2 months of age with development of a number of different findings. One that's key to kind of key in on would be maculopapular rash, specifically on the palms and soles. And we always hear about nasal discharge, also called snuffles. There can be generalized lymphadenopathy, fever, hepatomegaly, thrombocytopenia, anemia, meningitis, chorioretinitis, pneumonia, and osteochondritis. Interestingly, most infants are asymptomatic though, but may have low birth weight. And then other important things to keep in mind is the skin lesions and the nasal secretions of the infant are highly contagious. And so because of that, infants should be placed on contact precautions. However, organisms are rarely found in the lesions greater than 24 hours after treatment. So there's really that first 24 hours is the key time of transmission. Late congenital syphilis will then present after 2 years of age. It can have such things as Hutchinson teeth, mulberry molars, hard palate perforation, eighth nerve deafness, and a number of other symptoms as well. Interestingly, there is Hutchinson's triad, which includes blunted upper incisors, interstitial keratitis, and eighth nerve deafness. And here's just kind of some of the different pictures that can kind of highlight this for you. So again, one of those early manifestations is snuffles. There's the mulberry molars seen at the second picture over. There's the saber shins, which is a late finding at the third picture over. And then there's the radiographic finding of that as well. Diagnosis. So it's important to kind of keep in mind these non-treponemal versus treponemal tests. Non-treponemal antibody tests are the VDRL, so that's the Venereal Disease Research Laboratory test, and the RPR, so Rapid Plasma Reagent test. It's used for screening and monitoring of treatment during the disease. I do want to highlight again that monitoring of treatment during the disease. Treponemal tests include such things as fluorescent treponemal antibody absorption tests, particle agglutination, and there's also an enzyme immunoassay that's also used to confirm the diagnosis. Treponemal tests are not used alone because of the chance for false positives. However, they should be used as a confirmatory test if one of those non-treponemal tests, aka the VDRL or the RPR, do come back positive. The best way to determine an infant's risk for congenital syphilis, however, is to know the mother's status. Other important aspects as well are just the importance of making sure to have a documented VDRL or RPR on the mother prior to discharge of the infant from the hospital. So, interestingly, the non-treponemal antibody tests, aka the RPR and the VDRL, are what are used to measure the response to treatment, not the treponemal antibody tests. Those actually will remain positive for the infant, basically persistently. And then CNS disease can also be detected by examining the CSF and finding any kind of positive serologic tests. So treatment. All mothers should be treated for syphilis as part of their routine prenatal care. Again, no infant should be discharged from the hospital without documentation of the mother's serologic status for syphilis. And in addition to that, treatment of choice for treponema pallidum of infection at any age is penicillin G. So just to kind of go through a little bit of kind of some of the finer points for treatment. If an infant has proven or highly probable disease, which is a maternal positive RPR or VDRL with an exam consistent for syphilis, and then the infant has a non-treponemal antibody titer fourfold higher than the mother's titer, or positive direct visualization of a spirochete, then they should be treated for 10 days. If mother is positive but had an inadequate treatment or uncertain treatment, then it's okay to go ahead and do a single dose of IM penicillin G for the infant, and then to go and do the further follow-up studies for the infant to confirm their disease. And then if a mother is positive but was adequately treated during pregnancy, then you actually don't need to do follow-up examination or follow-up testing for the infant, but the infant can be given a one-time dose of penicillin G. So of note, syphilis follow-up, so all infants should be placed on isolation precautions, and then all infants of mothers who have a positive non-treponemal antibody testing should then have their the infants themselves should have follow-up testing at 3, 6, and 12 months. So now we're going to talk a little bit about varicella. So looking through some of the information for varicella. Caused by Varicella zoster virus, member of the herpes virus family, so aka the chickenpox virus. Route of infection, so Varicella zoster is transmitted through contact with fluid from vesicles or through airborne contact. Congenital varicella is acquired transplacentally. For varicella, it's particularly important to determine the time of maternal exposure and maternal onset of symptoms because it greatly affects what the infant symptoms will likely be. Of note, importantly, that reactivation of maternal varicella does not typically result in neonatal infection. And then, in addition to that, the overall incidence of varicella has decreased over the past 10 to 15 years, and that's presumably due to the increase in varicella vaccination. Also, additional information that's helpful is that varicella vaccine should not be administered to any pregnant women because it is a live virus. So incidence, so fetal varicella syndrome is about 1 to 5 cases per 10,000 pregnancies. So it's important to then be able to note for varicella the clinical manifestations, whether that's an infant who's infected before 20 weeks gestation. If that occurs, that's most likely to result in fetal demise. If maternal infection and subsequent fetal transmission occurs later in pregnancy, then there's a greater likelihood of the infant developing the typical varicella symptoms at birth. Of note, perinatal infection occurring several days or before birth actually can result in neonatal death as well. Some of the anomalies that can be associated with it include ophthalmologic malformations, cutaneous scarring, limb hypoplasia, and damage to the CNS. So looking at that, that's this cisatricial scarring as well as skin loss. There can also be microcephaly, seizures, encephalitis, cortical atrophy, spinal cord atrophy, mental retardation, and cerebral calcifications. You can also have ocular abnormalities, microophthalmia, chorioretinitis, cataracts, and can also have limb hypoplasia and then prematurity or IUGR. Looking at what some of these varicella pictures can end up looking like, so you can kind of get these circular scarring lesions that can occur that then can cause permanent scarring for the infant as well. So diagnosis, so varicella should be suspected in a mother who demonstrates classic signs for varicella, so prodromal illness with dewdrop lesions developing in a crop that forms crusts. In addition, an infant who presents with the typical vesicular lesions, you can do a PCR as well as do direct antibody screening. So talking a little bit about fetal varicella for treatment versus more of that late varicella or the infant type. So fetal varicella, a mother is exposed to varicella in that first or second trimester. So they should be treated with the varicella zoster immune globulin, and then infants should be treated with acyclovir. The varicella immune globulin should be given within 72 hours after exposure, and then supportive care should be given to ensure that there's not profound neurological impairment. Of note, the acyclovir that's given is used to stop progression of the eye disease for the infant, as well as the chance for recurrent zoster in the first 2 years of life. So some of the clinical manifestations for neonatal varicella can be mild symptoms, so including that rash that we were talking about. However, you can see lung involvement 2 to 4 days after the onset of rash. You can also see focal necrosis as well. Looking at neonatal varicella, that's more of kind of your late onset, so that's occurring within those first couple days of an infection. So if mom gets a varicella infection immediately prior to delivery or in the first couple days after delivery, that's where this infant is more likely to show up with lesions like this. So neonatal varicella, so that's again if the infant's having maternal exposure within 5 days before delivery or 2 days after delivery. That, in that case, varicella IVIG should be given to the infant. Also, varicella IVIG should be given as soon as possible, but not later than 10 days. Importantly, IVIG can be used if varicella IVIG can't be obtained, and then again, prophylactic acyclovir should be given 7 days after exposure. If IVIG is used for the infant, importantly, they should be placed on 28 days of respiratory isolation because they can make it more of a subclinical disease that then can reappear later on and end up basically being transmitted to others. Now we're going to talk a little bit about Parvovirus B19. So again, caused by Parvovirus B19, single-stranded DNA virus. Route of infection, so parvovirus is spread through respiratory tract secretions, exposure to contaminated blood, as well as transplacentally. Incidence, so typically occurs among school-age children, and the major symptom of that being erythema infectiosum. About 35% of women of childbearing age do not possess protective antibodies against parvovirus, and thus are susceptible to infection. So risk factors for parvovirus include school teachers, daycare workers, and then mothers of other school-age children. The pathophysiology, so in adults and children, a viremia typically develops about 2 days after exposure and reaches a peak at about 1 week. Patients typically are asymptomatic during this period, so it's important to note that you typically, and we'll talk about it a little bit, for like the slap cheek appearance, that's actually after the child would no longer be infectious to others, so they've actually already likely had a viremia that they're then spreading to others. Pregnant women will often have, again, this nonspecific flu-like illness and rarely develop the slap cheek appearance, and so with that in mind, it's not able to very well diagnose this for the mother. So clinical manifestations, so infants who are affected with parvovirus have risks of hydrops, pleural and pericardial effusions, IUGR, thrombocytopenia, as well as fetal demise. Infection during the first half of pregnancy confers the greatest risk to the fetus. Meanwhile, infected infants demonstrate the extremes of outcome with not much middle ground. So infants either typically have a lack of symptoms or very, very severe symptoms. If they're exposed in the third trimester, anemia and thrombocytopenia are also possible. Of note, for parvovirus, the risk of fetal death within the first trimester is actually 13%, 9% in the second trimester, and less than 1% in the third trimester. It's very possible that if a mother is exposed to parvovirus, that the infant can develop hydrops. That can rapidly progress to fetal death, or actually can resolve spontaneously as well. Spontaneous resolution can occur in up to 34% of the time. So looking a little bit at kind of some pictures here. So there's parvovirus with kind of that slapped cheek appearance over on the right versus fetal hydrops over on the left. So looking at diagnosis. So if a prenatal infection is suspected, maternal IgM and IgG can be obtained. A DNA PCR is also available and extremely sensitive, so it's the actual preferred method if you're going to test fetal blood. And then other important aspects to think about as well are, for infants, looking at fetal anemia. You can actually do a Doppler that can detect fetal blood flow in the middle cerebral artery. And so if you're likely to think that they have fetal anemia, it's worthwhile to consider parvovirus. So treatment of parvovirus. Treatment's actually limited to supportive care, unfortunately. If hydrops is diagnosed, then you can actually do more frequent prenatal ultrasounds to follow for how the infant's doing, how the fetus is, whether or not they're having resolution of their hydrops or worsening symptoms that would show for a need for expedited delivery. If the fetus is found to be anemic, so that's again looking at that middle cerebral artery, you can actually do intrauterine blood transfusions, or it actually gives you a little bit of better information as well for a need for PRBCs immediately following delivery. There have been some case studies that have looked at IVIG, however the data is limited on this, so it's not recommended at this time. Of note, if an infant does acquire parvovirus, they actually have no increase in developmental delay. And so again, this is kind of highlighting that aspect of not necessarily having long-term sequelae if there are no symptoms at all. Next, we'll talk a little bit about rubella. So rubella, also known as German measles, so it's a member of the Togoviridae family. So route of infection, rubella is spread through contact with respiratory secretions, both direct and droplet, as well as transplacentally. During the last major rubella epidemic, which was in the U.S. from 1964 to 1965, there was an estimated 12.5 million people who got rubella, 11,000 pregnant women lost their babies, 21,000 newborns died, and 20,000 babies were born with congenital rubella syndrome. Of note, today, less than 10 people in the U.S. are reported as having rubella each year. So this just kind of highlights the importance for rubella and vaccination. In the U.S., there's actually only 4 cases of congenital rubella between the years 2000 and 2005. And so it's just kind of, again, highlighting how you've had significant improvement in neonatal disease secondary to vaccination. So looking at risk factors, in places where there is no vaccination, 15 to 20% of women of childbearing age are susceptible to rubella. Additionally, you can also have women of childbearing age, even in the U.S. as well, who are rubella non-immune. And so it's just important to be able to make sure to look at that whenever you're going through prenatal labs. In addition, any women who are recent immigrants are also at risk for rubella. So some of the clinical manifestations. You know, systemic transient manifestations such as low birth weight, hepatosplenomegaly, meningoencephalitis, thrombocytopenia with or without purpura, the classic blueberry muffin rash, so that's the dermal erythropoiesis, lymphadenopathy, hepatosplenomegaly, interstitial pneumonitis, and radiolucent bone disease. There's also, importantly, some systemic permanent manifestations. Those include these branch pulmonary artery stenosis and PDAs, cataracts, and deafness. We'll highlight it again here in just a second, but there's also, interestingly, a salt and pepper retinopathy that's also another keyword just to keep in mind. So again, this is that blueberry muffin rash or the extramedullary hematopoiesis. Looking again at rubella clinical manifestations. So this picture over here on the left is highlighting rubella congenital cataracts. And then over on the right-hand side is the salt and pepper retinopathy. So complications. Fetal transmission during the first trimester often results in readily apparent sequelae at birth, such as congenital defects. You can compare that. Infection after 12 weeks can actually have no clinical manifestation, but is more likely to result in future hearing loss, visual problems, and affecting multiple other organ systems. As with toxoplasmosis, the earlier during gestation that an infection occurs, the more likely it is for it to be a severe disease. Eye problems that are associated with congenital rubella include microphthalmos, pigmentary retinopathy, cataracts, and again, congenital glaucoma. Cardiac manifestations include the peripheral pulmonic stenosis and PDA. Endocrinopathies can also occur, including diabetes mellitus. You can also have neurologic sequelae, including developmental delay, encephalitis, and then sensorineural hearing loss. So diagnosis. So a positive infant rubella IgM titer is indicative of recent infection. However, it can actually be complicated by both false positives and false negatives. As such, the gold standard for this is to do a viral culture. You can do this from body fluids, including blood, urine, CSF, and oral and nasal secretions. Interestingly, the oral and nasal secretions are the most accurate in terms of trying to obtain a viral culture. Diagnosis of congenital rubella is established by persistently elevated IgG titers over time as well. The IgM screening is reliable if it's obtained by 3 months of age. IgG is typically going to be followed at that 6 to 12 month age mark. And then you actually can't make the diagnosis for rubella greater than 1 year because of vaccination. Another interesting aspect that you can follow along for possible congenital rubella would be looking at imaging studies. So that's long bone films, looking for metaphyseal radiolucencies that could be metaphyseal osteoporosis. So treatment unfortunately is also limited to supportive care. However, due to the likelihood for developmental delays, it's important to consider referral for therapy services, and it's also a reportable disease, so the CDC should be notified if there's any kind of congenital rubella. Next, we'll talk a little bit about CMV, so that's cytomegalovirus. Looking at that, it's caused by cytomegalovirus and again classified as part of the herpes virus family, and it's the most common congenital infection in the US. CMV can be transmitted to an infant during pregnancy, so that's a transplacental transmission, during the time of delivery, so that's contact with infected genital tract secretions, or postnatally, and that's via ingestion of contaminated human milk or direct contact with other body fluids, urine, saliva, etc. So incidence, so prevalence of congenital CMV in live-born infants in industrialized nations is actually estimated to be about 0.5 to 1%. In the US, however, it's important to note that that's about 40,000 new cases of CMV every year. So here's just a little bit, kind of some pictures just to highlight some of the things that can happen with CMV. So looking at it, over here on the left is moderate to severe sensorineural hearing loss. Following over that as well, then you can also have these periventricular calcifications. I'll highlight this on another picture here in just a minute, but that's the A picture over here. Just important to contrast that CMV is going to have the periventricular calcifications. So again, just showing periventricular calcifications in comparison to toxoplasmosis, where you're going to have the diffuse intracranial calcifications. So some of the clinical manifestations. So the majority of neonates born with congenital CMV are actually asymptomatic at birth. Symptomatic infants with CMV can have such things as IUGR, microcephaly, periventricular calcifications, hepatosplenomegaly, jaundice, thrombocytopenia, and retinitis. The risk for fetal morbidity is increased when the mother has her primary infection during pregnancy, especially if it's during the first trimester. However, postnatal infection via human milk actually is unlikely to cause clinical sequelae because of the protective aspect of maternal antibodies that also come across in human milk. As such, it's actually not a contraindication for breastfeeding, and mothers with CMV are still able to breastfeed. Importantly, infants can end up showing some symptoms as well as hypotonia, lethargy, and poor suck. And preterm infants can have such things as apnea, bradycardia, and intestinal distension. If you do have a symptomatic infant, the mortality rate is as high as 20 to 30%. So some complications. So if they're symptomatic at birth, it again is going to show towards future morbidity. Approximately 1/2 or more of symptomatic neonates will have CNS sequelae. So those were ones that we were talking about, sensorineural deafness and developmental delay. If they're asymptomatic, fewer than 20% will develop CNS sequelae. There is an increased likelihood of developmental delay if an infant is having chorioretinitis, microcephaly, or intracranial calcifications. It's important to note that congenital CMV is the most common cause of non-hereditary sensorineural hearing loss in childhood. So diagnosis. Congenital CMV is diagnosed by demonstration of the virus in the body fluid, such as urine or pharyngeal secretions, within the first 3 weeks after birth. The virus can be detected in body fluids by culture or rapid centrifugation enhanced culture, or PCR as well. Viral culture is actually the gold standard, and so that's why we'll often end up doing that urine CMV. CMV treatment. Mothers should be encouraged to perform safe hygiene measures, including frequent hand washing, not sharing food, as that can reduce the transmission for CMV. Treatment with ganciclovir has been shown to improve both the chance of hearing loss, to make it less likely, as well as improving neurodevelopmental outcomes. Of note though, ganciclovir is associated with serious side effects, especially neutropenia, so infants should be monitored for neutropenia if they're treated with ganciclovir. And now we're going to talk a little bit about herpes simplex virus. I'm going to hand it over to Dr. Macriola.
Thank you so much, Vector, for for that very good presentation about the different congenital infection in the newborn. I hope you're having a good time in the areas where you are watching this presentation. Certainly, the coronavirus is definitely changing the way we do things, including the way we do grand rounds. So, knowing about this different congenital infection of the newborn will be a break, from thinking about coronavirus in your mind, I hope. So, I'm going to talk about herpes simplex virus, hepatitis B virus, and hepatitis C virus, for that matter. First, we're going to talk about herpes simplex virus. In the United States, 0.42% of newborn become infected with herpes simplex virus. When we think of herpes simplex virus, we think of vesicular lesions, just like what is shown on the picture. But I would like to highlight that 25 to 30% of the time, congenital herpes virus infection will not present with skin lesions. Rather, they're going to present as bacterial sepsis-like picture. So if you have an infant, if you have a newborn, especially a newborn during the first 3 weeks of life, presenting with septic-like picture, and in the CMP result, if it is showing elevated liver enzymes, or if there is prolonged coagulation status, then that particular situation, you should think of herpes in your differential. And since you're going to think of herpes, then you should start acyclovir right away. This is just the picture to show you the skin lesions, the oral mucosal lesions that can be attributed to herpes simplex virus infection. Now, there are 3 different types of congenital neonatal herpes. Number 1, herpes infection affecting the skin, the eyes, or the mucous membrane, a disseminated infection, or an infection involving the central nervous system. Now, this different classification matters in terms of treatment intervention, because if the herpes simplex virus infection is only affecting the skin, the eyes, or the mucous membrane without disseminated or CNS involvement, then treatment with acyclovir should only be for 14 days. But if it is involving the CNS, or if there is a disseminated infection, then acyclovir treatment should be for 21 days. Now, how do we diagnose someone with herpes in terms of laboratory intervention? We have to collect PCR specimens from the eyes, nasopharynx, perirectal, axilla, or the areas involved of the infection. And as I have mentioned earlier, CMP will be helpful because we will be able to detect elevated liver enzymes. And in some cases, there's going to be prolonged PT and PTT. The CBC picture, more or less, a lot of times it's going to be a normal white blood cell count with elevated lymphocytes. And if you're going to do CSF studies, you're going to see, you will be able to see an increased white blood cells with lymphocyte or monocyte predominance. And almost always, there's going to be an elevated red blood cell count. Before doing a spinal tap, make sure that you know the CBC result. Because if for some reason the patient has thrombocytopenia or prolonged PT and PTT, then it might be a good idea not to proceed with the spinal tap because you're trying to prevent intraspinal bleeding. Now, you might argue, what are you going to do in terms of starting IV acyclovir? You might have some thoughts that doing CSF studies later on might affect your PCR result in the CSF. Actually, even in patients who had been treated with acyclovir for 1 week, and you're going to do CSF PCR, the chances of having a positive result is still up to 98%. And even in patients who are being treated with acyclovir for 2 weeks, the chances of having a positive CSF PCR result is still 70%. So in other words, it does not seem to reflect that even if you're going to have IV acyclovir treatment, that is going to affect the positive result of your CSF PCR for herpes. Now, other diagnostic tests can also help you in trying to determine if there is CNS infection. EEG might be helpful. Now, in older patient, if you're going to do EEG, most of the time you're going to have a positive result coming from the temporal lobes. In newborn, however, you can have abnormal EEG that will be coming out from multiple areas on the brain. And MRI will help, because the MRI will kind of give you the idea, the extent of CNS involvement. Now the treatment, like what I mentioned earlier, IV acyclovir treatment should be given to those patients who have skin, eyes, or mucous membrane involvement, while 21 days for CNS or systemic involvement. Now, after the patient has been treated with IV acyclovir treatment, they need to be on oral acyclovir treatment for 6 to 12 months. This is to make sure that they're not going to develop neurodevelopmental delay. Studies have shown that in newborns who develop congenital herpes simplex virus infection, who have been treated with oral acyclovir treatment for 6 to 12 months, that their neurodevelopmental outcome is actually better. Mortality rate for herpes simplex virus infection is actually very high. It actually goes up. It's actually between 30 to 50%, even with adequate treatment. So it's a very virulent infection that actually this mortality is actually comparable to Ebola. So it's actually more virulent than COVID-19. So it's a viral infection that we should have high respect, and if we suspect someone, a newborn whom we suspect to be having herpes simplex virus infection, it should not be taken lightly. Hepatitis B. Up to 37.4% of acute hepatitis B cases had been reported in the United States to CDC since 2017. Majority of the newborn affected with hepatitis B infection are asymptomatic at birth. 40% of infants born to hepatitis B infected mom in the United States will develop chronic hepatitis B infection if there is no intervention. And think about it, 25% of this infant will develop bad complication of hepatitis B infection 20 to 30 years later. So if there's not going to be appropriate intervention during the newborn period, by the time an infant infected with hepatitis B will develop complication when they are between 20 to 30 years old. Think about that. Yeah. Now, because hepatitis B can cause major problems down the road, there have been guidelines that has been set up, currently every woman, every pregnant mom in the United States has to be tested for hepatitis B surface antigen during their pregnancy. Each time they're going to develop pregnancy, they should be tested. That doesn't mean that if they had a testing done during the previous pregnancy, that particular testing, even if it's negative, should carry over. A new testing should be done for each pregnancy. Now, if the hepatitis B DNA titer is more than 200,000, that would warrant intervention for the pregnant mom to prevent the pregnant mom from transmitting the hepatitis B virus to the infant. And if an infant had been delivered to a mom who has been identified to be hepatitis B positive, then hepatitis B immune globulin and hepatitis should be given within 12 hours. The same thing, hepatitis B vaccine should be given within 24 hours. Now, in a situation that you have a newborn, especially a preterm newborn who is less than 10 kilos, born to a mom who is hepatitis B positive, then you have to give the vaccine and hepatitis B immune globulin. But this hepatitis B vaccine that you have given, to a newborn who is less than 2 kilos should not be counted. By the time the child is going to be around 2 kilos, another hepatitis B vaccine should be given to that particular child. Now, I would like to highlight, the different hepatitis B serologies that can be done, because by knowing the result of these different serologies will give us a clue in terms of the status of the child or an infant in terms of the status of hepatitis B infection. And I would like to highlight, the lowest part of the table, that if you have a child who is hepatitis B surface antigen positive, anti-hepatitis B core positive, IgM core positive, and anti-hepatitis B surface antibody positive, that indicates that the child is acutely infected. And if a child is acutely infected, that's the situation that they have to be watched closely in terms of development of hepatic failure. Now, those newborn who had been delivered by moms who are hepatitis B positive should be tested for hepatitis B surface antigen or anti-hepatitis B surface antibody between 9 to 12 months of age. So that's very important, because if you're going to have a positive result at this time, then that tells us that the child had been infected. And those children who had been found to be infected should be followed up closely. And there are hepatitis B treatment indication that we have to follow for those type of children. Now, what are those? What are those indications? Now, if there is the presence of hepatitis B DNA greater than 20,000 international units per ml for more than 6 months, and if there is hepatitis E antigen positive result, then that could be an indication for treatment intervention. Likewise, if there is hepatitis B DNA greater than 2,000 international units with a positive hepatitis B antigen result, that could also be an indication for hepatitis B treatment intervention. At the same token, if you have an elevated ELT, and if there's evidence of chronic hepatitis B on liver biopsy, then that too can be an indication for treatment intervention. Now, these are the treatment intervention that had been found to be effective. They can be tried with interferon, lamivudine, and entecavir, adenofovir or tenofovir, or talbivudine, and this particular antiviral treatment can be given depending on the age of the patient. Personally, I would prefer, from my experience, I prefer entecavir because it does not have side effects. It is well tolerated in children. Hepatitis C. Around up to 5 million children worldwide develop chronic hepatitis C infection. And in our area, there is a direct correlation with opioid epidemic. As the numbers of women increase who had been found to be opiate addicted, then we also found an increased numbers of hepatitis C infection. Now, 25 to 50% of infected infants are able to clear hepatitis C infection on their own by the time that they're going to be 4 years of age. That's actually the good news, that even without treatment intervention, hepatitis C infection is going to be cleared by itself. There's an intensive research going on why this happened in children, because this particular phenomenon does not happen in adult. Now, the transmission of hepatitis C from mom to the infant is up to 5%. Now, if the viral load is high in the mom, then the chances of transmitting it to the infant is actually going to be high. Now, most of the newborn are going to present asymptomatic, but this particular newborn during their infancy should be watched closely in terms of their BMI, because it has been found out that if the BMI of these children who are hepatitis C positive is going to be on the abnormal side or is going to go up, then that actually increases the chances of cirrhosis or development of or acceleration of hepatic damage. I'd like to show to you the different genotypes of hepatitis C in the United States. The predominant genotype is genotype type 1, and genotypes 2 and 3 are almost the same incidence. And it is very important to know these different genotypes because the duration of treatment intervention actually varies depending on the type of the genotype that you are dealing with. Now, the good news is there are at least 2 treatment interventions which are effective to treat children who develop hepatitis C infection: Harvoni and Mavorix. These particular antiviral are very well tolerated without side effects. These children with hepatitis C who are 3 years old and above, can be treated with these 2 antiviral medication. The downside is these medications are actually very expensive. Harvoni, children treated with Harvoni has to be on this medication one capsule per day, and each capsule actually costs $1,200. So think about it. They have to be treated with this medication for a duration of at least 4 months. So total cost for treatment will come out to be up to $70,000 to $80,000. The good news is it is covered by Medicaid. But it's a lot of legwork, a lot of phone calls that we have to do in the clinic to make this treatment possible for our patients. So I think that's the end for our talk. And if you have some questions, we're ready to answer them if you have.
While we wait for some questions, I'll just highlight a couple of questions that just to kind of go over some of the information, just to show and highlight some of the different thoughts. So, one, you have a newborn presenting with IUGR, hepatosplenomegaly, jaundice, thrombocytopenia, petechiae, microcephaly, chorioretinitis, and periventricular calcifications. What's the most likely etiology? Look at that, it's most likely to be CMV. So it's again just highlighted by those periventricular calcifications. You can contrast that with a newborn with microcephaly, hydrocephalus, hepatosplenomegaly, maculopapular rash, retinochoroiditis, and widespread cerebral calcifications. That's most likely to be toxoplasmosis. Here's some references. And then questions.
So I thought that was a really great talk. I had a question kind of about two topics. I guess the first would be, having recently gone through the pregnancy counseling process, they talk about the cat box, they talk about not eating raw meat. They don't really talk about the dirt danger for toxoplasmosis.
Uh-huh.
How hazardous is that, really? Is it significant?
I think it's just the same aspect too of just being concerned for if you have like an outside cat, and then having the idea then of that you can have then exposure. It's the outside dirt if you have a cat in your neighborhood who likes to come around or something like that would still provide a risk. And so I think it's just trying to again limit exposure, that kind of thing. And so just trying to make it. It's not to say that you can't go out and garden at all, just if you're going to do so, to wear gloves and make sure to wash your hands well afterwards.
Fair enough. And I also had a question about the hepatitis B. In adults, we screen, I think, annually or every 2 years by ultrasound for liver cancer, which is one of the big complications. And I think the assumption is that a lot of adults were infected as adults, so they may have less advanced disease. Is that any concern in children at all, or in the pediatric population?
If for some reason there's going to be persistent elevation of liver enzymes, then doing an ultrasound is warranted, trying to determine if there is portal hypertension, Yeah.
Were there any other questions? Okay, well, thank you all very much.
Suki says nice suit.
Yeah.